every single minute. That is the ticking clock of the human body.
Oh, absolutely. It's a literal countdown.
Yeah. Every single minute, hundreds of cardiac cells can just suffocate and die when an artery is blocked. I mean, in the hospital setting, time isn't just money. Time is muscle.
That is the perfect way to phrase it. Time is muscle.
Welcome to an episode of the Super Nurse Podcast. This was created by Brooke Wallace. And we should mention, Brooke is a 20-year ICU nurse, an organ transplant coordinator, clinical instructor, and a published author.
Which is an incredible resume, but we need to make it explicitly clear right out of the gate, we are not Brooke Wallace.
No, we are definitely not. We are just your guides today. This episode is built directly from Brooke's bedside knowledge, her clinical notes, and that signature teaching style she has.
Right, because our whole mission here is to help nursing students and new nurses bridge that massive, totally intimidating gap between textbook theory and real patient care.
Yeah, the stuff you memorize for the NCLEX versus the actual living, breathing patient right in front of you.
Exactly, because reading about a concept in a quiet library is, well, it's a completely different experience from walking into a patient's room and hearing the monitor's alarm.
Oh, for sure. Seeing a critical event unfold in real time is terrifying at first. And before we get into all that clinical grit, I do want to invite you to subscribe and watch the video version of this episode on YouTube. The link is in the description, and the channel is called Super Nurse AI.
Definitely go check that out.
So today's clinical focus is on the realities of a myocardial infarction, an MI. What does a heart attack actually look like at the bedside?
Right. What are the immediate nursing interventions? And how do you anticipate what the provider is going to order next?
Because you always want to be one step ahead. And I know pathophysiology can feel like a totally foreign language in nursing school, so let's translate it into plain English.
Yeah, let's start with the plumbing, because fundamentally it is a plumbing issue.
Okay, lay it out for us.
So we all know the heart is a pump, right? Its entire job is to push low oxygen blood to the lungs and then squeeze the fresh oxygenated blood out to the rest of the body.
Right. But the heart muscle itself is like a living organ, too. It has to eat.
Exactly. It needs a continuous supply of oxygen to do all that heavy mechanical pumping. And it gets that fuel through the coronary arteries.
Those are those little vessels wrapping around the outside of the heart, right? Like a crown. I like to visualize the coronary arteries as like a major supply highway.
That analogy works perfectly. So think about atherosclerosis. It's this condition where a fatty, waxy substance plaque made up of cholesterol, calcium, and inflammatory cells builds up inside the walls of those highways over years.
Decades, even.
Yeah, decades. And an MI typically happens when that stable plaque suddenly becomes unstable.
Yeah.
It ruptures.
Wait, let me make sure I'm visualizing this right. The plaque isn't just like slowly growing until it plugs the hole completely. It actually breaks open.
Yes. It breaks open. The fibrous cap over that plaque physically tears. And the inside of that plaque is highly thrombogenic.
Meaning it causes clots.
Right. It violently triggers the body's clotting cascade. The body registers this tiny tear inside the artery as a major injury, just like if you got a huge cut on your arm.
Oh, wow.
So it sends out this massive emergency signal, and platelets just rush in to patch the hole.
Okay, so sticking with our highway analogy, the ruptured plaque is like a minor fender bender. But the platelets are the emergency vehicles rushing in to help, and they overreact so severely that they create a massive multi-car pileup.
Yes, they clump together and completely block all the lanes. That blood clot, the thrombus, is what seals off the artery.
And the cities downstream, the actual tissues of the heart muscle, they're instantly cut off from their fuel supply.
Exactly. No blood, no oxygen.
And what we know from practice is that downstream effect happens terrifyingly fast. I mean, the tissue starts starving right away, which is ischemia, right?
Right. Ischemia is the starving phase. But if that highway isn't cleared quickly, ischemia turns into infarction.
Meaning the tissue actually starts to die?
Yes. Tissue death or necrosis. And this brings us to the terminology you always see on charts. STEMI versus NSTEMI.
Right. Those acronyms are everywhere.
So a STEMI indicates full thickness muscle death. The entire wall of the heart muscle in that specific zone is dying because the blockage is 100% complete.
Okay, and an NSTEMI.
And an NSTEMI is partial thickness. The blockage is severe, but maybe not completely occlusive. And what we just described, the plaque rupture and the clot, that's a type 1 MI.
Okay, I know clinical instructors constantly quiz nursing students on the type 2 MI. That one always feels trickier because the pipes aren't necessarily clogged with a fresh blood clot, right?
Yeah, type 2 MI is a supply and demand mismatch. So the highway lanes might be completely open or maybe just slightly narrowed by old plaque, but the heart is suddenly demanding way more oxygen than the body can deliver.
Or the supply has dropped for some other systemic reason.
Exactly. Think about a patient in severe sepsis or someone with profound hypotension. Their blood pressure is just too low to physically push enough blood into those coronary arteries.
So the muscle still starves, but the mechanism is totally different.
Right. But knowing that the heart muscle is actively suffocating in a type 1 MI makes the body's reaction make total sense. It starts setting off massive systemic alarm bells.
Which is a perfect pivot to how this actually looks when you cross the threshold into the patient's room. Because, Hollywood gives us all this very dramatic image of a heart attack.
Oh, for sure. The classic Hollywood presentation is the older man clutching the dead center of his chest, grimacing, falling to his knees.
Right. And do we actually see that?
We do see those classic symptoms. That clutching of the chest actually has a clinical name, Levine sign.
Levine sign, got it.
And patients will describe a crushing, heavy pressure. They very rarely call it a sharp pain. They say it feels like an elephant is sitting on their chest.
It's usually left substernal pressure, right? Radiating up to the jaw or down the left arm. The radiating pain has always fascinated me. It's referred pain, right? Because the nerves supplying the heart and the nerves supplying the jaw and left arm all enter the spinal cord at the same general level.
That's the exact physiology. The brain literally gets confused about where the screaming is coming from.
That is so wild.
And you won't just see pain. You're going to see a profound sympathetic nervous system response. Fight or flight is in full effect because the body literally knows it is dying.
So what does that look like visually?
The patient will likely be severely short of breath. They'll exhibit profound diaphoresis. They are sweating straight through their gown. Their skin is incredibly pale and they feel cool and clammy to the touch.
Because the blood flow is being shunted away from the skin to protect the vital organs.
Right. And you also see a lot of severe nausea and vomiting.
Which is partly that massive surge of adrenaline, right? And partly the vagus nerve getting stimulated if the infarction is on the bottom or inferior wall of the heart.
You nailed it. But we really need to highlight a crucial bedside nuance here. Human bodies don't always read the textbooks.
They really don't.
The evidence tells us that this classic presentation isn't always what walks through the emergency room doors, especially in three specific populations: women, the elderly, and diabetics.
See, this is where the real anxiety lives for a nursing student or a new grad. I want to push back on this a bit.
Go for it.
If a patient with diabetes comes in just looking pale and complaining that they are incredibly fatigued, my first thought as a new nurse might be, oh, their blood sugar is off. Am I supposed to instantly jump to heart attack every single time someone is tired?
It is completely valid fear. You don't want to panic over every tired patient, but you absolutely cannot afford to miss an MI. It's a classic error of omission.
Right.
The physiological why behind the diabetic presentation is neuropathy. Patients with poorly controlled diabetes develop nerve damage over time. Because those sensory nerves are deadened, they literally might not feel that classic crushing chest pain.
They can have a silent MI.
Exactly. The heart muscle is suffocating and dying, but the alarm bell that's supposed to signal pain because it essentially had its wires cut.
Wow. And what about women?
For women, what we know from practice is they frequently experience atypical symptoms. They might complain of severe, unexplained fatigue that just comes on suddenly.
Or pain in their shoulder blades, right? Or what simply feels like terrible heartburn and indigestion.
Yes. So going back to your fear of missing it, if the subjective symptoms are unreliable, if they don't have the crushing chest pain, we have to rely on something else.
Right, because we can't just guess based on indigestion.
We never guess.
Yeah.
We transition immediately from relying on their subjective complaints to gathering hard, objective data.
Any unexplained sudden upper body symptom or sudden profound fatigue, especially in those vulnerable populations, warrants immediate investigation.
We have to go looking for the footprint the heart is leaving behind.
And the absolute fastest way to see that footprint is electrical.
Which leads us to the diagnostics. When we suspect an MI, what is the very first move? The 12-lead EKG. It functions as the sixth vital sign in this scenario.
And there's a strict timeline for that, isn't there?
Yes. The standard of care is that if a patient reports chest pain or those concerning atypical symptoms, an EKG must be performed and interpreted within 10 minutes of their arrival.
Because time is muscle.
Exactly.
The EKG gives us a snapshot of the electrical activity of the heart from 12 different camera angles. And the big red flag we are looking for is ST elevation. But let's explain why that ST segment physically lifts up on the paper.
It comes down to electrical conductivity. Healthy heart muscle cells hold a specific electrical charge, and they conduct electricity seamlessly.
Right.
But when tissue dies, it loses its cell membrane potential. It becomes a literal electrical roadblock.
Yeah.
The electrical signal trying to travel through the heart hits that dead muscle and has to detour around it.
Oh, that makes so much sense. That detour, that sudden change in the electrical vector, is what the EKG machine reads. It alters the baseline, physically pushing the ST segment up on the tracing for the leads that are looking directly at that damaged wall.
You've got it. ST elevation indicates a major emergency. It means the blockage is full and the muscle is actively dying.
And what if we see ST depression or an inverted T wave?
The electricity is still struggling, but it usually indicates ischemia, a partial blockage, or an instemi.
Okay, so the EKG gives us the electrical chaos in real time. But we also need to look at the blood. We need the cardiac biomarkers. And the superstar here is troponin.
Troponin is the absolute gold standard for cardiac biomarkers.
What exactly is it?
When cardiac cells are starved of oxygen and die, their cell membranes break down. They burst open.
Yeah.
And when they burst, they leak their internal proteins directly into the bloodstream. Troponin is one of those specific proteins.
So under normal circumstances, troponin belongs inside the cell, helping the muscle contract. It should not be floating around in the blood in high amounts.
Correct. A normal level is generally between 0 and 0.4 nanograms per milliliter. Anything over 0.5 indicates cardiac trauma.
And the higher the number, the more extensive the muscle damage. I always think of troponin like a smoke detector in your house. If a fire starts in the kitchen, the smoke detector goes off. But even if the firefighters show up and put the fire out quickly, that alarm is going to keep blaring while the smoke clears from the room.
That's a great way to put it.
I know we check serial troponin levels drawing blood every few hours. If the fire's already out, what exactly are we hoping to see on that trend line?
Well, troponin levels don't rise instantly. It takes about 2 to 4 hours after the initial injury for them to even show up in the blood, and they can stay elevated for up to 14 days.
Oh, wow. Up to 2 weeks.
Yeah. By checking serial troponins, we track the trend. Is the number steadily climbing from 0.5 to 2.0 to 5.0? That means the fire is still burning. Cells are still bursting.
But if it's peaked and started to decrease...
That tells us the infarction has stopped extending, and we can assess the total size of the damage based on how high that peak was.
Okay, that clarifies so much. You might see other markers mentioned in textbooks, like CKMB or myoglobin, but clinical experience shows troponin is really the primary driver for decisions at the bedside today.
It absolutely is. So we have the clinical picture. Our EKG shows ST elevation, and the troponin is climbing. The diagnosis is confirmed. Now the nurse has to act fast.
Let's talk about the bedside interventions. For decades, the gold standard memory trick taught in nursing schools was MONA, right? Morphine, oxygen, nitroglycerin, and aspirin.
Yes, but modern evidence-based practice has really shifted away from just blindly applying all 4 of those. We use a much more targeted approach now.
Let's break down why we are rethinking MONA, starting with oxygen. The old reflex was that anyone clutching their chest immediately got oxygen slammed on them. I mean, if the heart is suffocating, give them oxygen, right?
It seems perfectly logical, but the evidence tells us that unnecessary oxygen can actually cause harm.
Really?
If a patient is oxygenating well on room air, NSPO2 of 94% or higher, we do not add supplemental oxygen. Excess oxygen in the blood can create reactive oxygen species, which are free radicals that damage the already vulnerable cardiac tissue.
Furthermore, high levels of oxygen can cause coronary vasoconstriction, right? The vessels actually clamp down a little bit, which is the exact opposite of what you want when there is already a blockage.
Exactly. So we only apply oxygen if their saturation drops below 90%.
Okay, next up, aspirin. The typical dose is 162 to 325 milligrams. And the crucial instruction is that the patient must chew it immediately, not swallow it whole.
Yes, chewing it gets it absorbed through the oral mucosa much faster.
We need to clarify what aspirin actually does in this moment, because a lot of people think it's a clot buster. It does not break up the existing clot, does it?
It does not. Aspirin is an antiplatelet. Going back to our highway analogy, the multi-car pileup has already happened. The lanes are blocked. Aspirin acts like a police barricade further up the highway.
It prevents more platelets from rushing in and making that clot even bigger.
Right. It buys us time.
Now, what about nitroglycerin?
Nitroglycerin is a potent vasodilator. It forcefully opens up the blood vessels. The goal is to dilate the coronary arteries enough to hopefully allow a little bit of blood to trickle past the blockage, or to open up collateral side streets to get some oxygen to the starving tissue.
And it's usually given sublingually, right? Under the tongue.
Yes. The standard protocol is a maximum of 3 doses spaced 5 minutes apart.
But the nurse cannot just hand them a pill. There are massive, non-negotiable safety checks that have to happen before giving even a single dose of nitro. Missing this is a huge medication error.
Oh, absolutely. First and foremost, you must check their blood pressure. Nitroglycerin doesn't just dilate the coronary arteries, it dilates vessels all over the body.
That systemic vasodilation causes blood pressure to drop.
Severely, if the patient is already hypotensive, giving them nitro could crash their pressure to a fatal level.
Second, you absolutely must ask the patient if they have taken any phosphodiesterase inhibitors recently. These are medications like sildenafil, commonly known as Viagra.
Usually prescribed for erectile dysfunction or pulmonary hypertension. Those medications are also extremely potent vasodilators.
So if you combine them with nitroglycerin,
The compounding effect can cause a sudden, profound, and irreversible drop in blood pressure that won't respond to standard resuscitation efforts.
wow.
You have to ask the question directly, regardless of how awkward it feels. It's a matter of life and death.
And there is a very practical physical detail here, too. Why do we always ensure the patient is sitting or lying down before we administer that sublingual nitro?
Because of gravity. When you suddenly widen all the blood vessels in the body, gravity is going to pull the blood straight down into the legs.
So if the patient is standing up when that
The
happens,
sudden lack of blood flow to the brain will cause severe orthostatic hypotension. They will pass out, fall, and hit their head. Now you have a cardiac emergency and a traumatic brain injury.
not a good day. Finally, we get to the M in MONA, morphine. This is used much more conservatively today, right?
It is. It's typically reserved for severe pain that is entirely unrelieved by the nitroglycerin. The goal of morphine isn't just pain relief, though.
It's a mild vasodilator, right?
It is, but more importantly, it deeply reduces anxiety. By calming the patient, it decreases the sympathetic nervous system response, which in turn decreases the cardiac workload.
But it can mask worsening symptoms, so it is no longer an automatic first step.
Right. All these medications, the chewed aspirin, the nitro, the careful use of morphine, they are critical for buying time. They stop the clot from getting worse, and they ease the workload on the heart.
But they do not clear the blocked highway. To fix the fundamental plumbing problem, we have to move to definitive interventions.
The ultimate goal for a STEMI is getting the patient to the cath lab for a PCI, a percutaneous coronary intervention.
This is where the cardiologist actually goes in and clears the wreckage.
Exactly. The provider threads a catheter, usually up through the radial artery in the wrist or the femoral artery in the groin, right into the coronary arteries.
And then they inflate a balloon.
Yeah, they locate the blockage and they inflate a tiny balloon to flatten that ruptured plaque and clot against the artery wall. This physically opens the lumen back up.
And then they almost always leave a stent, right? A tiny wire mesh tube to act as scaffolding and keep the vessel propped open.
That's standard practice. The national goal for this is a door-to-balloon time of 90 minutes.
From the minute they hit the ER doors to the minute that balloon inflates and restores blood flow.
Exactly.
But, not every hospital has a cath lab. If you are in a small rural facility, what is the plan?
If you cannot get them to a cath lab within that time frame, the next best option is thrombolytic therapy.
These are the serious clot busters.
Yes, medications usually ending in oboles, like eltaplase or tenecteplase. Unlike aspirin, these drugs actively dissolve the fibrin matrix of the existing clot.
They literally clear the road.
Right. The goal is to administer these within 120 minutes of medical contact.
Okay, so let's say the intervention is successful. The vessel is open. The patient comes back up to your ICU or step-down unit. As the nurse managing their recovery, what orders are you anticipating next?
You should expect to initiate an IV heparin drip. We just put a foreign object, a middle stent, into a highly irritable artery.
So the heparin keeps the blood thin and prevents a brand new clot from forming directly on that fresh stent.
Exactly. And within the first 24 hours, you'll also anticipate starting them on beta blockers and ACE inhibitors.
Okay, I have to stop and push back here because this is a classic nursing school brain twister that trips people up on exams and at the bedside.
It really does.
We know that a damaged, infarcted heart is incredibly weak. It is at high risk for cardiogenic shock, which means dangerously low blood pressure and poor cardiac output.
Right.
So why on earth are we anticipating giving beta blockers, which we know specifically lower the heart rate and lower the blood pressure? Isn't that like kicking a horse when it's down?
It's a fantastic question. It all comes down to delicate timing and clinical judgment. Giving a beta blocker at the wrong time is a huge medication error. You are absolutely right that if a patient is actively in cardiogenic shock, or if they are severely hypotensive immediately after their MI, Giving a beta blocker would be disastrous.
It would crash whatever compensation they have left.
Absolutely. However, if the patient is hemodynamically stable, giving a beta blocker within the first 24 hours is incredibly protective.
How so?
Think about what the sympathetic nervous system is doing. It's dumping adrenaline, whipping that damaged heart muscle to beat faster and harder. A beta blocker blocks that adrenaline.
It forces the heart to rest.
Yes, it lowers the heart rate just enough to reduce the tissue's demand for oxygen, preventing further ischemia. You anticipate the order, but you critically evaluate your vital signs before you ever push the medication.
That makes perfect sense. It's not just blindly following a protocol. It's understanding the why and the when. We also mentioned ACE inhibitors.
Right. Those help prevent cardiac remodeling, basically stopping the heart from changing its shape and stretching out abnormally as it heals from the trauma.
And while you are administering these meds, you are constantly monitoring for complications. What is the nurse watching for post-intervention?
Cardiogenic shock is the big physiological failure, but you are also watching the monitor like a hawk for lethal arrhythmias.
Because dying tissue is angry tissue.
It really is. When heart muscle is damaged, its electrical pathways are totally scrambled. It gets incredibly irritable.
And that irritability causes the heart's electrical system to misfire, leading to sudden, dangerous rhythms like ventricular tachycardia or ventricular fibrillation.
Exactly. The patient can seem totally fine 1 minute and be in cardiac arrest the next, purely from an electrical short circuit caused by the earlier plumbing problem.
Man, by understanding this entire trajectory from the exact cellular moment that plaque ruptures, to the physiological reason behind the sweat and the nausea, to the mechanics of the EKG detour and the precise logic behind the medications, a nurse is just so much more prepared.
You really are. You aren't just memorizing a checklist of tasks. You understand the mechanism of the disease, and you understand how your specific actions directly counteract it at a cellular level.
So to recap the core lessons we've covered today, time is muscle.
The longer the blockage, the more necrosis occurs.
Trust your clinical assessment over subjective complaints. If a diabetic or a female patient presents with vague, sudden upper body symptoms or profound fatigue, get the hard data.
Get that 12-lead EKG done within 10 minutes. Watch the troponin trend to gauge the size of the fire.
And understand the logic behind your interventions. Apply oxygen only if the saturation is below 90% to avoid vasoconstriction. Make sure the aspirin is chewed so it stops the platelet pileup immediately.
And perform rigorous safety checks, especially blood pressure and a history of erectile dysfunction medications, before ever administering nitroglycerin.
You know, a truly phenomenal bedside nurse is a detective. They don't just wait for the textbook symptoms to appear. They actively hunt for the silent clues to catch the heart attacks that others might just brush off as fatigue or indigestion.
That really is the difference between passing a nursing exam and saving a human life. It requires critical thinking, pattern recognition, and the confidence to advocate for your patient when the presentation isn't straightforward.
I want to leave you with one final provocative thought about the psychological aspect of bedside nursing. Think about a patient actively having a heart attack.
Okay.
The sheer primal terror of that experience causes their body to dump massive amounts of adrenaline. That adrenaline spikes their heart rate and skyrockets their heart's demand for oxygen that it currently cannot get because the highway is blocked. It creates a vicious, deadly cycle.
The panic literally accelerates the muscle death.
Yes. So think about how your calm, competent bedside manner isn't just about being a nice person. Your ability to walk into that room, project calm, communicate clearly, and take control actually acts as a direct physiological intervention.
That's a powerful way to look at it.
By lowering their anxiety, you are literally lowering their sympathetic response and therefore lowering their cardiac workload. You are helping save that heart muscle just by the way you present yourself in a crisis.
That is where the deep science of pathophysiology and the profound art of nursing intersect perfectly.
It really is. Thank you so much for joining us for this episode. Don't forget to head over to YouTube, search for Super Nurse AI, and watch the video version of this discussion.
Hit like, subscribe, and please leave us a comment about a time you caught a tricky clinical presentation at the bedside.
And be sure to visit supernurse.ai for incredible resources designed to help you bridge the gap between school and practice and become the super nurse you were born to be. Catch you next time.